Good morning. And I actually, although this talk is titled An Obese 2-Year-Old, a Mother and a Doctor Walk Into the Room, that is the topic, but I think that I had changed it to a 2-year-old child with obesity, just to be clear that I think that we're moving into a world where I think we want to have children with obesity, adults with obesity, and not obese adults and children, and just move away into something that doesn't label our patients and children. These are the goals today, and they're lofty goals. And I have woven a case into this talk to illustrate things I think that you know, and maybe some things you don't know, but mostly it's an approach to the young child. And I think I'll preface this with the goal for the young child is the healthiest possible diet, the healthiest possible diet. So the quality of the diet and the quality of the physical activity are the first goals for our youngest children who are very much at risk. So this is a case of D.E. She's a 10-month-old girl. Her parents brought her in. You can see her height, weight, and BMI there. The weight's about 50 pounds. So already we know we're in trouble. I have a weight management clinic, so we see quite a few of these kids. Mom's bringing her in because of her attitude. Okay, this is a 2-year-old with an attitude. Who doesn't know a 2-year-old with an attitude, okay? But when denied food, Mom's description of her is she demands food. When denied food, she falls to the ground, cries so hard she vomits. And this behavior has been occurring since she was 1-year-old. So we know this child. Many of us know this child, right? And this presents a whole host of issues when this child has obesity. So this is her weight. This is her height. She's at the 95th for height, and this is her BMI, okay, at age 2. Now, I'm seeing her for the first time at age 2, so this is what I have to work with. We know that the prevalence of obesity in young childhood is high. 11% of children under 1 year have a greater than 95th weight for length, 17% of children 1 to 2, 12 to 13% of children 2 to 3, 15% of children 3 to 4. So this is a problem that has drifted down into our youngest children, and I might say the comorbidities have drifted down too. So do I have 4-year-olds with liver disease? Yes. Do I have lipid problems in my 3-year-olds? Yes. So I'm not sure there's a lower limit for how far this can drift down. So there was a review of, this will set the stage for some of the review of what we are contending with in infancy and toddlerhood and what we might think of what are modifiable feeding and activity practices that we can change. So we're really looking at the rate of weight gain during infancy and how to keep the children on the growth chart. Just like we did with Failure to Thrive, we're trying to get them back on the growth chart. We're trying to keep these kids on the growth chart. We're looking at obviously promoting breastfeeding and introduction of proper introduction of complementary foods, diet quality and quantity. Okay, diet quality and quantity. We're looking at parent feeding practices, and we'll talk a little bit about the extreme importance of the feeding dyad. Okay, the child and the parent, physical activity, TV time, sleep duration, and family meals. These are not surprising things to be looking at, but based on the literature, these are the modifiable things that we have in our toolbox to work with our families. So Dee.E.'s birth weight was 7 pounds. Her delivery was 33 weeks. Mom has obesity. Father's normal weight. Mom had gestational diabetes and preeclampsia. She was a little early. Mom didn't remember her gestational weight gain. Okay, so you're looking for intrauterine factors that would prompt obesity. Mom is diabetic. We know that there's a prenatal risk for postnatal obesity. We know that the intrauterine environment is critical, and the things that alter that environment are critical to promoting an increased risk of obesity and later possibly diabetes. So the maternal diabetes or gestational diabetes during pregnancy, maternal obesity, maternal smoking, intrauterine growth retardation, and maternal gestational weight gain are all intrauterine factors that produce a child who is at increasing risk. So not only is the environment worsening and maybe the environment stabilizing, I would hope, but the intergenerational risk continuum continues. And so we have to pay a lot more attention, I think, to what's happening in the intrauterine environment to our adolescent girls of reproductive age, and not much more easily said than done. And of course, family high-risk nutrition and activity behaviors, because this is about high-risk behaviors for obesity, and the child falls right into exactly where the parents and family are with their behaviors. So just like you've heard, infants who had one or both parents overweight were more likely to have a weight at or above the 90th percentile at 6 months. This can happen very early. So Nick Stetler would say that if you lift off that growth chart by 4 months, you're already indicating that you are at higher risk. And that's going to be a child that we need to get back on the growth chart. Families with one or both parents, and another way of framing this, Rob Whitaker did this many years ago, showed that the prevalence of obesity in young adulthood was very high if you had parents who were obese, and your chances of not being obese with one or more parents obese were maybe 15%. So this shows the multi-genetic, kind of polygenetic risk, or the environmental risk, or a whole cluster of risk factors that we deal with in these families. So obesity really is a multi-generational disease, and you're working with the family constellation. So what about the intrauterine environment and early nutrition? And I'll just spend a minute or two talking about epigenetics. And as you know, epigenetics is the study of heritable changes in gene expression that are not mediated by DNA sequence alterations. Your genome is not changed. What is changed is that you have methyl groups and histone acetyl groups adhering to the DNA and changing the gene readout. And these methyl groups and these histone acetyl groups are susceptible to environmental influences. So as we eat our environments, as we behave our way into environments, and there are many studies in animals on this and beginning studies in people, we are changing the readout of our genomes. And that change lasts into the next generation. So these epigenetic changes change access to the transcriptional machinery, and it changes the phenotype of the person, even in the absence of environmental stimuli. So these changes stick, and you can remove the environmental stimuli, and you're still in an altered state. So this has transformed our understanding of the importance of the intrauterine environment, of infant feeding, of the impact of the environment, how absolutely crucial this is. And this really stemmed from Barker's work on studying middle-aged and elderly adults in England, when he looked at birth weight and he looked at later cardiovascular disease and diabetes, and he said the smaller babies were more at risk. I think it took him 10 years to get this work published. Nobody really could believe that something that happened to you in the intrauterine environment could have that long-lasting an effect. But now we have come to understand the mediator for this is probably epigenetics. And overnourished in animals, there's a lot of data about overnourished suckling rats having impaired glucose-stimulated insulin secretion, and this persisted after they were normalized to a normal diet. And these genes that control this are imprintable genes susceptible to these influences. So as pediatricians, as people interested in early childhood and infant feeding, we are at a crucial point because this is cumulative. And I think that we were seeing the additive effects of these influences over time in people's lives. And infancy is a crucial point of intervention. So we're back to our case, and Mom said she feels the weight gain started when the patient went to the babysitter when Mom got a job. So when asked, did you breastfeed your baby? Mom says, yes, for 9 months. However, at 2 months, she went to the babysitter who also bottle fed her. Okay, so the breastfeeding history, the breast and bottle feeding, it's exclusive breastfeeding. You have to be careful to ask about all scenarios because when asked if you breastfeed, yes, you breastfeed. There's a lot of breast and bottle feeding going on at the same time, and that'll become important in a minute when we talk about bottle feeding. So infant weight gain, who's more likely to be obese in childhood? What are some of the baby factors? In this particular study, those without private insurance, born by C-section. Born by C-section has increasing relevance now as we understand the microbiome of the gut flora. When you are squeezed through that birth canal, you are coated with gut flora from your mom. And we now know there's a difference in the gut flora between somebody who has obesity and somebody who is a normal weight. So C-section now has a whole different impact. We are not getting what we possibly need in terms of our microbiome and our preparation for energy metabolism. Higher birth weight babies, mothers who were had obesity at pre-pregnancy, or at 4 to 5 years where obesity was sustained after pregnancy, and then rapid weight gain in the first 4 months of life. So these are some infant predisposing factors to obesity. What about infant feeding? Where do parents go for infant feeding information? They can go everywhere. They want infant feeding information from us, but they also go to relatives and friends and the popular literature. So these are some infant feeding touch points for us. Breastfeeding and obesity. Breastfeeding, at the Academy, we say 5210 breastfeeding. Breastfeeding has a viable obesity preventive impact. My take on some of the earlier studies is that the impact was greater. The environment can overwhelm this. So if you're breastfed, you can still have obesity because we live in an overwhelming environment now, but it's there. And I'll tell you in a minute some of the factors why we think it's there. So there's a reduced incidence of obesity in breastfed infants, which is dose dependent. The longer and more exclusively you breastfeed, the better this gets. It may result in altered body composition. In children breastfed for at least 6 months or more, the risks of obesity were reduced by 40% in this particular study. So absolutely worth promoting for all the best reasons and all the reasons we know. But we also know that there are some cytokines in breast milk, not only immunologic factors and nutritional factors, but leptin is in breast milk. Leptin is also produced by the placenta. Leptin is a satiety and growth factor. What's it doing in breast milk? We're not exactly sure, but it may be helping to regulate satiety. Cultured mammary gland cells produce leptin, and leptin is present in the milk fat globules of the breast milk. And this is just a slide from some of our earlier work, staining for leptin in milk fat globules. So not only do we have all the good reasons to promote breastfeeding, we have satiety factors coming through in the breast milk, and they get absorbed into the circulation. So what about formula? If you can't breastfeed or you're not breastfeeding, what about formula? What should we do about that? Well, I think we have to begin looking at the infant feeding dyad, and I have somewhat of a mission in the hospital. We have breastfeeding rooms in the hospital. We need infant feeding rooms in the hospital. We need places where mothers can go to feed their infants. We need to promote healthy mother-infant interactions around feeding and not disenfranchise our formula-feeding moms. Sometimes they can't breastfeed. There are many intervening factors, and I just make a plea for you to think about the infant feeding dyad. We want to pay exquisite attention to satiety signals so people know when the baby is full and when the baby is hungry, and you all know this. Parents do not know this. So this needs to be taught to parents how you read your baby, how you interpret those signals, how you interpret those cries. But there's more to it than that. So there is a belief that infants and young children are born with a capacity for self-regulation that sort of gets actuated when the mother responds exquisitely to those cues, and that if met with a good response, the baby will have self-regulated feeding. And that might not be entirely the entire story. It's true that mothers who were more responsive and sensitive to their infant during feeding had infants who cried less, had greater attachment, compared to mothers who followed rigid feeding schedule. All of this is good. What's it doing to the feeding dynamics? In this particular review, there were no differences in infant weight gain between mother, educated about responsive feeding, and the controls. So this is necessary, I think, but possibly not sufficient for all babies. Why? The mechanism of feeding may be important. So in this slide, you see that bottle feeding of formula or breast milk results in excess weight gain in the first 12 months. And you can see that bottle feeding, breastfed babies were the sort of control. Human milk and formula feeding by bottle, formula by bottle, human milk by bottle. What is going on? What is going on? If it's not, is there something about that bottle feeding that's happening here, even that can overwhelm even human milk? So infants who emptied bottles in the first 6 months of life were much more likely to have excess weight gain. So the rapidity at which and the volume an infant will take in and the suck rate of the infant may have something to do with this. And children of parents with obesity had greater sucking rates at 3 months than those of normal weight parents. So again, I don't know that we have all the answers, but we do understand that there's something about the feeding dyad and the matchup of the mother's responses and what the baby comes to us with that is really important. Okay? So specific eating behaviors may be there, and I have taken many histories of parents who said the suck rates are different, and they're very high sometimes in these infants, and I'm not sure why. I'm not sure why, but I know that we have to pay attention to that dyad. And then Elsie Tavares' work that shows among breastfed infants, the timing of solid food introduction was not associated with increased obesity, but among formula-fed infants, the introduction of solid foods before 4 months was associated with a much higher increase in the odds of obesity. So feeding mechanisms, timing of solid foods may differ. If you're feeding an infant with a bottle, maybe that's triggering earlier introduction of complementary foods. I just hold this out to you to show you the complexity of the infant feeding dyad and what we're dealing with. So promote breastfeeding. Obviously teach cued feeding. Consider other factors besides hunger. Solid food, I would say 6 months. Nutritional hygiene of the whole family. The infant will go the way the whole family goes. And then tummy time needs to be scheduled. I have to ask parents to actually schedule tummy time. After you eat, wait 20 minutes, down for 20 minutes. They're not putting the babies down. They're just not putting them down. Babies aren't going in any which way getting activity. So back to our case. What's key about this is that there are 2 siblings that still living in Mexico. So this baby, I think, is a very precious baby to mom because she's left 2 other children in Mexico, and I think that's important to understand. She's had some dental work because of baby bottle caries, so that tells you something. And mom has type 2 diabetes and arthritis. There's hypertension in the family as well. So the baby's at risk from a family history of diabetes. What you see in the review of systems is that mom is worried she might have arthritis. She has lower extremity pain. That was mom is clearly, we have a dyad that I think is mom has arthritis, maybe the baby has arthritis, mom's worried about the baby, a lot of worry here. Didn't have anything in her lower extremities, was referred by her primary care. Mom's worried about her attention span. Attention span of a 2-year-old is about this big, right? Tiny little attention span. So, of course, she's not paying attention. But that tells you some of the concerns that mom has. Worried about illness, worried about attention span, understanding of development, not sure where mom is. Physical exam, was fun, like a 2-year-old exam. She's running around the room. Mom's not controlling her. I'm jumping up and down. Liver was down a little by auscultation. Worried a little was her liver accumulating some fat, as often happens with obesity. I wanted to talk a little bit about what was going on with her diet. And we know I like this graph. It's just the changes in food sources during the first 2 years of life. This is a rapid food transitional time. It's critical. And once those food changes change, and about 9 months, the kid's eating exactly like their family. They don't change after that. Once you start eating like your family, it's very hard to change. It's very hard to change. This is my reminder to when you're looking at polyphagia and weight gain, not to forget the genetic syndromes that are associated with obesity. We're not going to talk about that today, but we need to be aware that mixed in with all these little children with obesity are genetic syndromes that we really need to call out and need our special attention. Prader-Willi is very common. At 1 in 10,000 babies to 15,000 babies has Prader-Willi, and so in your practices you will possibly have 1 or more of these children. So this is data from the Fits for Toddler study, and it shows you that at about 9 months, or between 9 and 12 months, the dietary pattern gets established and really doesn't change much out till at least 5. So the critical time for establishing the dietary mix of food groups is that critical transition time, and then it doesn't change much. And then we have to work to change it if it isn't good. So I'm not going to go over these in great detail, only to say her daily routine, there's a couple high points. When dad's home, and she's home all day, and when dad's home and is trying to feed her, she plays with her food and asks for cookies and chips. So she's got dad figured out. okay? And she naps 3 hours in the evening and doesn't go to bed till 1 a.m. So this is a child who is just in free float, at home, no, why have a schedule, no real schedule, okay? Drinking water, juice, and milk from a bottle, does never go out, never goes out, okay? So, I ask sometimes, I used to ask, how much time do you spend outside? And now I say, do you ever go outside? No, never goes outside. I had a 12-year-old tell me at a visit, she said, Dr. Hassink, you know I don't go outside. I was raised indoors. I'm an indoor child. Okay. All right. Indoor child. All right. So we're starting with indoor children right here at 2. Okay. Never goes outside. Mom has been home from her job for the past 2 months. Things are improving a little bit, but boy, the kid's still a big problem and is up at night asking for food. So mom has started to wait out the crying jag at night for food, but the kid's up at night. Sleep. As we all know, sleep duration has been recognized as a modifier of childhood obesity. So children who got less than 9 hours of sleep had 1.5 times the risk of being obese as those with greater than 11 hours at night. So in this dysregulated scenario that I'm painting for you, everything is dysregulated. Sleep, eating, activity, it's all in, like Chris would like to say, it's all chaos at this point. And we're trying to help mom. So at meals, 2 ways for a child to get in control of their diet. I can either demand food and get in your face, or I can refuse food. If I demand food, I pester you until you give in, and if I refuse food, I make you feel guilty because you're not, I'm not eating, and then I'm not going to get enough food. So her favorite foods are chicken nuggets, French fries, or eggs. Mom's trying to be calm during these tantrums, but what's mom doing? Telling the child, just take a deep breath. It's not working for mom. Sometimes she thinks it works, sometimes it's not. And then if it does not work and the child tantrums, the child will then cycle into asking for her bottle. She was still taking a bottle at 2. So failure to transition. Father, I love this. Dad was present and for the first visit, and I said, he said, when she asks me for food, I give it to her. So I said, why do you do that? Why don't you say no? He said, well, I never say no because I don't like saying no to her. Just don't like it. I'm not going to do it. So we now know a little bit more about the family system, right? Mealtimes are characterized by slow eating, running back and forth. Mother says every time they go to the store, the kid puts chocolate in the cart. Mom takes the chocolate out. We have a tantrum. So that's this grocery store scenario. So temperament and behavior has also been associated with risk of overweight. Children with persistent tantrums over food and highly emotional temperaments were at increased risk for overweight. You can kind of see why that might be. And then parenting skills. So if we're not teaching cooking, where are they getting parenting skills? Where are parents getting parenting skills to deal with anger, temper, emotions, around boundary setting? Okay, crucial set tools in your toolbox to deal with a child in this scenario. Okay? And sometimes I put the dental caries one in there because sometimes parents care a lot about teeth, and that's a hook. You can get them to learn some skills around boundary setting if you roll the dental carie thing in. So goals worked out with the parent at the end of the first visit. Trying to work together to eliminate sugared beverages and snack food from the house. Not going to be easy, but trying to work together. Reducing the milk, regular meals. And we cycled her in 2 weeks. So these little kids I cycle back fast because in chaos like this, it's hard to hang on to any behavioral changes for very long. So if they can do anything, I want them to do anything, do it quick, and I can reinforce it quickly. Okay? And I'm lucky, and those dietitians in the room, I love you because we work with our dietitian. So this is from her note. Okay, these were the diagnosis that we had for this child. This is the diet history, and I just direct your attention to nutrition issues identified, still unstructured eating, selective eating, inability for mom to plan appropriate meals, and nutritional, not good adequacy nutritionally of the diet. So these were the nutritional targets for that 2-week visit. The weight did come down. The parents reported decreasing intake. She now is drinking from a cup and not with a straw, not a bottle. But mom's putting Splenda in the milk. And so we have this confounding kind of situation where mothers are it's like one thing cancels out another. They'll use diet products and overfeed the child. They'll use Splenda and give candy. And so I think I go back to Dr. Dedekian's, like, we have lost our way nutritionally, and we're thinking that I had a mother giving a pre-diabetic boy Glucerna in the morning with his meals, which is an extra 250 calories, thinking that would somehow treat his diabetes. So, it's just we have lost our way. Okay? But again, important to note, my dietitian says frequent temper tantrums again. So frequent temper tantrums are going to be the theme here. So what did we do here nutritionally? We all use motivational interviewing to goal set, trying to coordinate our care. And the nutritional goals for that 2-week visit were 3 food groups at meals, trying to boost nutritional adequacy, fruit for a snack, and it was not big goals, okay? But we're moving quickly. So now we have a 1-month dietitian visit. That's 2 weeks from the last visit, okay? This is a cleaner looking diet here. I'm not going to belabor that. The previous nutrition goals were met. Okay, the 2 goals we set were met. And then new nutrition issues identified. Still unstructured eating, tantrums still. Mom says things are going okay, but patient's still crying because she wants more food, but mom's trying to distract her and does not give her more food. And she's been dancing around the house with mom because you're always trying to add exercise in. So we're making small progress. Mom's feeling a little bit more in control of the situation. Okay, nutritional goals. Fruit with breakfast, balanced planned meals. Keep reinforcing that message, reinforcing mom's good work. So she became a toddler, like a 3-year-old, while we were seeing her. So at my second visit, her weight has gone down. The mother reports that she's giving her more fruits and vegetables whenever she wants a snack. No sugar beverages, yay. Scheduled meals. No bottle. Okay, we're really making progress here. She's getting oatmeal at night because mom eats oatmeal at night. But mom's been struggling with depression. And this is not unusual, as you know, with a depressed mom, that the acting out of the child escalates to kind of get mom engaged. So we have a depressed mom who we're trying to get into care and deal with this feeding dyad still. D.B.E still tantruming. Mom's trying to reason with her and distract her, and we're trying to give her some tantrum management skills along the way. But we're losing weight, okay? So we're talking about routines and management of the tantrum in the grocery store. There's no way mom couldn't take, I never have people, my patients, take their kids to the grocery store. I think that's just not a place for children, at least now. Because the cereals are all at child eye level. The checkout lines are full of candy. It's the huge profit center in the checkout lines. Until we revamp grocery stores, I think it's take them to the farmer's market. Please don't take them to the grocery store, because then you have to manage all that behavior while they're there. Okay, so here she is. We're congratulating her, and congratulating is very important, very important. That's why you cycle people back, so you can reinforce the positive behavior and really congratulate people when they're doing well, especially since she's having her own struggles. And then we tried to reorder her laboratory studies, which we ordered in the first place and weren't done. So household routines. Why routines? Because in a large sample of children, 3 household routines were associated with a reduction in the risk of obesity. Eat the evening meal with a family, adequate sleep, limit TV time. Okay, if you had all these 3 routines, your prevalence was 14% compared with 24% of children with none of these routines had obesity. So routine, we've done some sort of market research at the Academy. Parents like the word routine much better than schedule, so it's routine. And this is just the household routine graph, okay? So the dinner, sleep, and screen time were 3 routines, at least in this study, that were consistently associated. More routines, the better you did. So toddlers. Toddlers are not doing well here. Many of them are consuming sweetened beverages, less than 10% seed green vegetable, potatoes and french fries are the vegetable, and a lot of them are eating candy and dessert. And this is a picture from the UK. This was, I think, the baby they took away from the family in the UK. This was in the newspaper for obesity. So parents are concerned. It's not that the parents are not concerned. They're concerned about how much their children should be eating. Are they eating too much? Are they eating too little? They're frustrated because the kids don't want to eat the green beans because they can have french fries. So parents are concerned, and they're pretty frustrated. And over again, the control is in the hands of the child. So a mother came to me a little while ago and was very proud. Her 2-year-old now can operate the microwave. Okay, great developmental step. You know, mom's very proud. It operates the microwave to get her own food, right? 5-year-old going into the refrigerator picking his own snacks. 13 and 14-year-old, when asked by me, I said to mom, who plans dinner? Who picks the menus at dinner? She said, they do. What do you mean they do? The 13 and 14-year-old? Yeah. One night the 13-year-old picks dinner, and the next night the 14-year-old. So a lot of control of food decision-making has gone from the parent, which is the traditional food decision-maker, and as long as probably humans have been around, to the child, who has now become a major food decision-maker, mainly based on taste. And there's a lot of reasons for that. Parents need to provide healthy food in the right proportions. Children decide what to eat. So in talking to Leanne Birch, because we had the thought that children could self-regulate up till around 5, and it was going to be okay, and then you might have to set boundaries. And in talking to Leanne Birch, who's sort of my guru for young child feeding, she said, no, really, we're in an age where we have to restrict access. We have to set boundaries around convenience foods and fast foods. That's our job. And if you hide the food, or if the child knows the food's in the environment, that's the problem. The family has to shift. The family has to shift to a healthy nutritional environment and normalize healthy eating at this point. Preschoolers presented with age-appropriate and double-sized portions, obviously, there is more there. You will eat more. That's a human behavior. So portions are a major driver of consumption, as taste is. So increased daily intake, increased bite size, more likely to eat in the absence of hunger when there's a big portion there. So helping folks understand what a toddler portion is crucial. And often it's not an adult portion, and it's not the portion your 10-year-old son is eating. So people don't really have a good appreciation of what a toddler should be eating. So back to our case, she had their last 4 visits, we're working the weight down. This is her daily diet, not so bad. Not so bad. We're scheduling, okay? Dinner is oatmeal, but still not so bad, okay. Weight loss or maintenance goal was met. Fruit for breakfast goal was met. Balance plan snacks. At this point, mom's doing well. This is 2 months in to her visit. Nutritional issues, still some unstructured eating, inability to plan appropriate meals. So how do you get a healthy meal on the table? You have to manage your money. You have to know how to shop. You have to know how to cook. Okay? So it's a multi-step process. Still tantruming. So tantrums ebb and flow. And we're still dealing with helping mom deal with the tantrums. Patient's going to bed now between 8:30 and 9, better than 1. She's going to bed with mom, but mom's still trying to get her routine sorted out at this visit. These are just labs. We do run a whole screening panel of labs in our morbidly obese little ones because we do see some changes early. Fortunately, she did not have changes, but we do see some metabolic changes as young as 2 in some kids. So 2-month visit again. Mother said she's attentive and mindful at home, but when she's on the phone or takes her out, things are not going well. So things are going better at home. Still, she's acting up in the store and when mom's preoccupied. So we were lucky because she had a tantrum in clinic. How many of you ever had a child who tantrumed for you in clinic? Isn't that great? I love that because now we can demonstrate in real life how the child will not die if they cry, right? It will be okay. So we took mom to the other side of the room, and we just sat there taking deep breaths, mom and I, while the child cried and screamed and then looked up, and we didn't move. Moved 2 steps closer, cried and screamed, moved closer, cried and screamed, moved closer, finally looked up and crawled into mom's lap. So we were able to demonstrate that, 1, you will not die of a tantrum, that you can contain. Whose anxiety are we trying to contain? We're trying to contain mom's anxiety about this child, and that the child will still love you if you do not immediately respond to that tantrum at the first whimper. The other kind of food tantruming is still tantruming, and food whining is still whining. So we treat food whining as whining, and we head it off before the tantrum. So whining is whining. If it's about food, it's still whining. Tantruming is tantruming. If it's about food, it's still tantruming. The trouble is when it's about food, it gets very, very visceral for the mother or father or caregiver, and it pulls on your deep-rooted fear that you might be starving your child. And I don't say that glibly, because having asked many parents, what will happen if your child doesn't eat this meal? Many parents of children with obesity will tell me they will starve. So I don't say this glibly. I think there's a deep-seated fear of starvation or hunger, maintaining that hunger. We'll talk about hunger in a minute. And right now we'll talk about hunger. So hunger and satiety, we're always working along this hunger and satiety continuum. And many things can trigger hunger. I think, to me, this is sort of the complexity. Almost every under 5-year-old child I see, many older ones too, comes in with the complaint of always hungry. Always hungry. Why are they always hungry? I'm not sure why they're always hungry. There's parental obesity and early eating behaviors. There's psychological state, the state of your hypothalamus, your leptin, genetic syndromes, drugs. There's external stresses and eating for comfort. There's highly palatable foods with the bliss point engineered in so that we will keep consuming. There's food exposure, what's around, and portion size. And there's food marketing and conditioning. The point is many, many things drive that complaint of hunger. And you have to take it seriously because to the child it's real hunger. They feel it. And you have to get underneath it to try to figure out what can I do to ameliorate it. Do I want to reduce food cues? Do I want to reduce TV commercials? Do I want to stop incessant food talk at the table? What do I want to do to kind of damp this down? And this is just what we're used to looking at from the hypothalamus down, with all the regulatory systems that can regulate energy intake and expenditure. But this is from the hypothalamus up. And this is sight, smell, taste, habits, learning, okay? Reward. So when you start linking food to reward, the reward circuit is extremely powerful in your brain, and that link is very hard to unhook once people get to think about the reward center and food occurring the same thing. So food in our culture has become largely, not always, because we have a lot of food insecurity, we do, and I'm not going to minimize that. But for many people in developed countries, food is somewhat discretionary and is driven by palatability, okay? And so the taste of food may be replacing normal hunger as the determinant of the increasing proportion of energy that we take in. So 3-month dietitian visit, we're still working on some of the same problems. Now we're going into picky eating. So the things don't stay the same. So the child's moving into that phase where she's now sort of choosing her food, starting to become picky, triggered mom's anxieties again. A child was sort of whiny in the nutrition visit, a hard visit to have. Still trying to talk about press on, talk about tantruming, continue the plan, improve activity. So parents exhibit the greatest control over the domains that they believe the child has difficulty with, or they themselves have struggled with, or they believe the child do not have the capacity or self-control to deal with. So the parent's response is often a read both on the child and the parent. So the parent's either responding to where they feel the child can't respond, or responding in areas maybe by restricting that because they have difficulty with food control. So it's always a dyadic. The parent response when you start to intervene is always based on both sides of the equation. That's just a point. So picky eating, we all know how to do that. It can be influenced by parents and siblings in the home, peers, social contexts of eating, praise or negative response for consuming certain foods, media, and advertising. Picky eating wouldn't seem like it's a problem in obesity, but it is a problem in obesity because when you're a picky eater, you're now gaining control of your food, and parents will respond by feeding the child what they want to have. Okay, so in the toddler years, picky eating is significantly associated with whether the mother considered her child to have a feeding problem. and wasn't normalized. If they didn't normalize this and know that you just have to keep exposing the child to fruit and vegetables, they maintain the picky eating. So self-regulation, in preschoolers' use of typical external cues resulted in lack of self-regulation. You're trying to build self-regulation, but if you're timing them to eat, if you're making them clean their plate, if you're rewarding them for consumption, that inhibits self-regulation. So in a setting where you can provide the right food in the right amount, if they're not hungry, wrap it up, they'll eat it later, and don't regulate them like this, you're going to help enhance their self-regulation and their internal cues. So at the 4-month visit, she had stabilized her weight over the last 6 months and decreased her BMI. Mom reported she was cooking less greasy foods, cutting down on the bread, the tortillas, and the flour. Occasionally now the child was sneaking some, and that's another point of intervention. But Mom is trying to distract her and do this in a way, not talk her down like an adult, but treat her like a child. She's using a regular cup. Mom's trying to keep calm during the tantruming. Mom's trying to praise the child when she does something right. And obesity under 5 is a rapidly growing attention point that we have to pay attention as early as humanly possible. They have maximal access to us in pediatric visits and daycare and situations where we can intervene. It's an important period for establishing lifelong nutrition and activity behaviors. Parents need parenting information and skills desperately, and it's an opportunity to do cumulative prevention and the same message over and over. This is a little picture for you of it's from one of Leanne Davison and Birch's socioecological model. It's sort of the toddler, it's the weight socioecological model. Just for your review, you can teach from this. You can circle these things and show it to a family. It's a very useful tool. And I just want to review in the last 2 minutes some toddler points. Toddlers may have inappropriate access to food. They may be getting their own food. They may be getting the food that the grandma has in her room or the mother's hiding. The child's demands for food may be met with inconsistent responses depending on how many family members or caregivers are feeding the child. There's a lot of grazing in toddlerhood. There's strollers with drink cups. Kids are eating all the time, and that's a behavior that's become normalized. Portion sizes are excessive. Parents don't recognize beverages as food, as sources of calories, and uses of food of reward and comfort are triggering that reward center. Time spent outdoors strongly correlates with physical activity, and free play has dropped. And parents just assume they're going to get activity because they're running around your room, but they're not getting enough activity. Television in the room is very hard to get out. I don't know how you stop it from getting in, but once it's getting in, you can't get it out. And parents laughed at us at the Academy when we did a study and said TV shouldn't be in the room, and they said it's educational. There's so many good reasons to have it. So I think we're still trying to get that message right about the TV and make it stick. And then activity patterns are really formed in childhood. And so children may lack activity opportunities, and the parent may not know that they've been inactive all day in daycare and may not have them go outside. Activity may be episodic and not sustained because toddlers stop and go. They stop and go, so they need a length of time to be active. You can't say be active for 5 minutes because their play pattern is stop and go, stop and go. Older caregivers may be more inactive, and the kid adopts that style. And the right hand may not know what the left hand is doing, so you have to ask what's happening at daycare, what's happening at grandma's, what's happening at your house. This is her BMI chart after 4 months. Okay? And I brought this case to show you kind of the complexity and the staying with the same messages that has to occur in a situation that at 2 you think, how at 2 could it be this complicated? Right? I mean, I take care of lots of adolescents, and I can understand at 16, when you weigh 450 pounds, it's really complicated. But at 2, it's very complicated for a family. And I just want to add that this was all done by translation because this was a Spanish family. So we had the phone most of the time. And that's how we did our work. And that's why she didn't see a psychologist, because the psychologists don't like using the phone to do their psychology visits. So we have a limited number of Spanish-speaking psychologists. So this was all done by phone. So anyway, that's sort of our world. And I think, and the need to focus on these very youngest children under 5, under 2, under 1. Okay, thank you.